Bismillahirrahmanirrahim. I am Dr. Talat Chaudhary. This lecture is about shock. This chapter is taken from Bailey and Love, latest edition, that is 28th. So the definition of shock is a systemic state of low tissue perfusion that is not adequate, that is inadequate for normal cellular respiration, with insufficient delivery of oxygen and glucose to cell. Cells switch from aerobic environment to anaerobic. So if the perfusion is not restored in a timely fashion, cell death occurs. So it is a complete definition of shock from Bailey and Love. Shock is a systemic state of low tissue perfusion that is not adequate for normal cellular respiration. Shock is the most common cause of death in surgical patients, or in other words, the most common cause of death on a surgical floor is shock as a whole. We will discuss the pathophysiology of shock at cellular level, at microvascular level and systemic level one by one. So at a cellular level, when there is an insufficient delivery of oxygen to cells switch from aerobic metabolism to anaerobic metabolism, and the product of anaerobic metabolism or anaerobic respiration is lactic acidosis, and accumulation of lactic acidosis produces metabolic acidosis. So at a cellular level there is a metabolic acidosis due to insufficient delivery of oxygen. Cells switch from aerobic to anaerobic metabolism. The product of anaerobic metabolism is lactic acidosis. At a cellular level, accumulation of lactic acidosis produces metabolic acidosis. Furthermore, as the glucose within the cell is exhausted, anaerobic respiration stops or ceases. There is a failure of sodium potassium ATPase pump in the cell membrane as well as intracellular organelles. Intracellular lysozymes release autodigestive enzymes. Cell lysis occurs. As a result of cell lysis, there is a hyperkalemia. So at a cellular level there are two main things that happen. There is a metabolic acidosis as well as hyperkalemia. Both metabolic acidosis and hyperkalemia occurs at a cellular level due to shock. The pathophysiology at a microvascular level. When there is a low tissue perfusion, there is a metabolic acidosis and hyperkalemia at a cellular level. Both metabolic acidosis and hyperkalemia causes activation of immune system and coagulation system. There is a production of oxygen free radicals and cytokine release. Both oxygen free radicals and cytokine causes injury to capillary endothelial cells. Capillary becomes leaky and there is a tissue edema. So at a microvascular level there is a tissue edema. At a level of systemic, all the four systems are affected by shock. There are changes in CVS, respiratory, renal and endocrine system. In cardiovascular system, there is a preload as well as there is afterload. Decreased preload and decreased afterload produces compensatory baroreceptor response that causes increased sympathetic activity and release of catecholamine that are adrenaline, non-adrenaline. As a result of catecholamine release, there is a tachycardia and vasoconstriction. So in cardiovascular system, there is a decreased preload, decreased afterload produces tachycardia and vasoconstriction. In respiratory system, there is a metabolic acidosis produces compensatory respiratory alkalosis. As a result of metabolic acidosis, there is an increased sympathetic activity. There is an increased respiratory rate and increased minute ventilation. There is an increased excretion of carbon dioxide. So, compensatory respiratory alkalosis occur. In respiratory system, metabolic acidosis causes compensatory respiratory alkalosis. In renal system, there is a decreased perfusion pressure in the kidneys, decreased filtration at the glomerulus, there is a decreased urine output. As a result, there is a activation of renin-angiotensin-aldosterone system, that is RAAS. It causes sodium reabsorption and vasoconstriction. In endocrine system, there is a release of cortisol, renin-angiotensin-aldosterone system, and vasopressin, that is antidiuretic hormone. There are several ways for the classification of shock. The classification which is present in Bailey and Love, it is based on the initiating mechanism. Classification which is present in Bailey and Love, it is based on the initiating mechanism. So the types of shock are hypovolemic shock, obstructive shock, distributive shock, cardiogenic shock, and endocrine shock. So there are 5 types of shock mentioned in Bailey and Love: hypovolemic shock, obstructive shock, distributive shock, cardiogenic shock, and endocrine shock. First type is hypovolemic shock. It is due to reduced circulating volume. It is due to reduced circulating volume. It is the most common form of shock. To some degree, hypovolemic shock is a component of all the other forms of the shock. Hypovolemic shock is the most common form of the shock. The causes of hypovolemic shock are non-hemorrhagic causes as well as hemorrhagic causes. In non-hemorrhagic causes, there is a decreased fluid intake, that is dehydration. Number 2 is excessive fluid loss due to vomiting and diarrhea. Third is urinary loss in diabetes insipidus. Fourth is evaporation in a dry and hot environment. Fifth is third spacing. Fluid is lost into gastrointestinal tract in bowel obstruction and interstitial spaces in case of acute pancreatitis. So the other causes, the group is hemorrhagic causes in case of traumatic, trauma to abdomen, trauma to limb, trauma to chest. The second type of shock is obstructive shock. There is a reduction in the preload due to mechanical obstruction of cardiac filling. There is a reduced filling of heart leading to low cardiac output. So the causes of obstructive shock are tension pneumothorax, cardiac tamponade, massive pulmonary embolism, and air embolus. These are the causes of obstructive shock. Third category is the distributive shock. It describes following conditions including septic shock, anaphylactic shock, and spinal cord injury. The cause of sepsis is related to release of bacterial products, that is endotoxin, in case of septic shock. It causes the activation of cellular and humoral components of the immune system. There is a maldistribution of blood flow at a microvascular level that causes AV shunting, arteriovenous shunting, and dysfunction of cellular utilization of oxygen. In later phases of septic shock, there is a hypovolemia and myocardial depression. In anaphylactic shock, there is a vasodilation. It is due to histamine release. And in high spinal cord injury, there is a failure of sympathetic outflow and adequate vascular tone, that is neurogenic shock. So in distributive shock, there are 3 types of shock: septic shock, anaphylactic shock, and neurogenic shock, that is spinal cord injury. Remember, In distributive shock, there are three types of shock: septic shock, anaphylactic shock, and spinal cord injury, that is neurogenic shock. Next variety of shock is endocrine shock. In endocrine shock, there is a combination of hypovolemia, hypovolemic shock, distributive shock, and cardiogenic shock. Causes are hypothyroidism, hyperthyroidism, and adrenal insufficiency. Again, endocrine shock is a combination of hypovolemic shock, distributive shock, and cardiogenic shock. Hypothyroidism causes a shock-like state that is similar to neurogenic shock due to disordered vascular and cardiac responsiveness to circulating catecholamines. Cardiac output falls as a result of low inotropy and bradycardia. There is also associated cardiomyopathy in case of endocrine shock. Thyrotoxicosis, that is hyperthyroidism with associated symptoms. Thyrotoxicosis causes the high output cardiac failure, and adrenal insufficiency leads to a shock-like state due to hypovolemia and poor response to circulating and exogenous catecholamines. This is the table which is mentioned in Billy and Love. Cardiac output is high only in case of distributive shock. In all other types of shock, there is a low cardiac output. So cardiac output is only high in case of distributive shock, as well as mixed venous saturation is also high only in case of distributive shock. Systemic vascular resistance is low only in case of distributive shock. In all the types of shock, that is hypovolemic, cardiogenic, and obstructive, there is an increased systemic vascular resistance. Base deficit is high in all types of shock, and venous pressure is low in case of hypovolemic shock as well as distributive shock. There is a term that is unresuscitable shock. When the ability of the body to compensate is lost, it is unresuscitable shock. When the ability of the body to compensate is lost, it is unresuscitable shock. Patients who remain in the state of shock for a prolonged period of time become unresuscitable. There is a cellular ischemia. Cellular ischemia leads to cell death, and ability of the body to compensate is lost. It is unresuscitable shock. The pathophysiology of unresuscitable shock is when there is a metabolic acidosis and hyperkalemia at a cellular level. It leads to myocardial depression. There is a poor cardiac output, low cardiac output, and a limited response to fluids and inotropic therapy. In periphery, there is a loss of ability to maintain systemic vascular resistance, and there is a hypotension. Metabolic acidosis and hyperkalemia at a cellular level causes hypotension as a systemic cause. There are 3 degrees of shock: mild according to severity, mild, moderate, and severe. First is the pulse rate. Pulse rate is raised or high or tachycardia in all types of shock: mild shock, moderate shock, and severe shock. Blood pressure is normal in case of mild shock. There is a mild hypotension in moderate shock and severe hypotension in severe shock. There is a tachypnea, that is increased respiratory rate in case of mild as well as moderate shock. There is labored breathing in case of severe shock, and patient is mild. There is a mild anxiety in case of mild, drowsy in moderate shock, and comatose patient in severe shock. Urine output is normal in case of mild and reduced below 0.5 ml per kg per hour in moderate shock, and anuria falls to 0 in case of severe shock. Lactic acidosis is 1 plus in case of mild, 2 plus in case of moderate, and 3 plus in case of severe shock, and pulse pressure is low in case of mild shock. One term is multi-organ failure. It is defined as two or more failed organ system. Multi-organ failure carries a high mortality rate, that is 60%. And the management of multi-organ failure is organ system is ventilation, number one, cardiovascular support, hemofiltration, that is dialysis, until there is a recovery of organ function. So multi-organ failure is two or more failed organ system. Next term is reperfusion injury or ischemia reperfusion and systemic inflammatory response syndrome. During the period of systemic hypoperfusion, there is a cellular damage and organ damage. It continues due to the direct effect of tissue hypoxia and local activation of inflammation and inflammatory substances that causes the cellular damage and organ damage. Once the normal circulation is restored to hypoperfused area, further injury occurs. That is the reperfusion injury or ischemia reperfusion. In heart, there is a cardiovascular failure. In respiratory system, there is a ARDS. In kidneys, there is a AKI, acute kidney injury. In liver, there is a liver failure and coagulopathy. In CNS brain, there is a cerebral swelling and dysfunction. So this is the reperfusion injury. Reperfusion injury can only be attenuated by reducing the extent and duration of tissue hypoxia. So further pathophysiology of reperfusion injury is when there is a low tissue perfusion. At a cellular level, there is a metabolic acidosis and hyperkalemia. That metabolic acidosis and hyperkalemia causes the activation of immune system and coagulation system. There is a myocardial depression, vascular dilatation, vasodilation, and further hypotension. There is oxygen free radicals and immune modulator cytokine release, complement system activation, neutrophil release, and microvascular thrombi. These overcome the local inflammatory response when the normal circulation is restored. These local inflammatory substances are flushed back to circulation, causes further injury. That is the in cardiac or severe system, there is a cardiovascular failure. In lung, there is a acute respiratory distress syndrome, ARDS. In kidney, there is AKI. In liver, there is a coagulopathy and liver failure. In brain, there is a cerebral swelling and dysfunction. So this is the reperfusion injury or ischemia reperfusion. The other term is compensated shock. Compensated shock is the shock when body's cardiovascular compensatory response and endocrine compensatory responses reduce the blood flow to non-essential organs to preserve the preload. For example, the non-essential organs are skin, muscle, skeletal muscle, and the gastrointestinal tract. These organs are underperfused, their cells are respiring anaerobically, and there is anaerobic metabolism or anaerobic environment in their cells and sustaining ischemia damage. And blood flow to the kidney, lung, and brain is increased. This is the compensatory response or compensated shock. Body's cardiovascular responses and endocrine compensatory responses reduces the blood flow to non-essential organ and increases the blood flow to the essential organs, that is the brain, kidney, and lungs. So apart from the tachycardia and cold peripheries, there may be no signs of hypovolemia. Sometimes patient present with occult hypertension for more than 12 hours have a significant high mortality rate, high infection rate, and high incidence of multiple organ failure. So definition of occult hypoperfusion is metabolic acidosis despite the normal urine output, and cardiorespiratory vital signs. Loss of 15% of the circulating blood volume is within normal compensatory mechanism. Uncompensated shock occurs when when 30 to 40% of the circulating volume has been lost, and the blood pressure only falls when 30 to 40% of the circulating blood volume has been lost. Remember, loss of 15% of the circulating blood volume is within normal compensatory mechanism. Loss of 15% of the circulating volume is within normal compensatory mechanism, and uncompensated shock occurs only when 30 to 40% of the circulating volume has been lost. Further loss of the circulating volume overleads the body's compensatory mechanism, and there is a progressive renal, respiratory, and cardiovascular decompensation. Shock, there are two main categories: compensated shock or uncompensated. Compensated shock is mild, and uncompensated is further divided into two: moderate shock and severe shock. Capillary refill, it is not a specific marker of whether a patient is in a shock. Most patients in hypovolemic shock will have cool or cold pale peripheries with prolonged capillary refill times. Capillary refill, it is not a specific marker. It is not a specific marker whether the patient is in a state of shock or not. In distributive shock, the peripheries will be warm and capillary refill will be brisk, and despite profound shock. So patients with short capillary refill times may be within the early stages of shock. But remember, capillary refill, it is not a specific marker of whether the patient is in a state of shock or not. Tachycardia may not always accompany the shock. Although tachycardia is an early sign of shock, but may not always accompany the shock. Patients who are on a beta blocker or who have implanted pacemakers are unable to mount the tachycardia. An example is mentioned in Bailey and Love. If a pulse rate of 80 in a fit young adult who normally have a pulse rate of 50 is very abnormal. In some young patients with penetrating trauma, whether there is a hemorrhage but little tissue damage, there may be a paradoxical bradycardia rather than tachycardia. Hypotension is one of the late signs of shock. Early sign of the shock is tachycardia, and hypotension is one of the last or late signs of shock. Young adults, children, and fit young adults are able to maintain blood pressure until the final stages of shock by how the blood pressure is maintained. It is maintained by increase in stroke volume and peripheral vasoconstriction. Patients can be in a profound state of shock with a normal blood pressure. Patients can be in a state of shock with a normal blood pressure. Elderly patients who are normally hypertensive may present with a normal blood pressure for a general population in a state of shock, but may be hypovolemic and hypotensive relative to their usual blood pressure. Beta blockers and other medications may prevent a tachycardia or tachycardic response. Remember, tachycardia is an early sign and blood pressure is one of the late sign. This is the shock from Bailey and Love. Hope this lecture helps you a lot. Thank you so much.